as we look back, PEPFAR and the U.S. response to the global AIDS epidemic is going to be remembered as one of the truly historic demonstrations of generosity and compassion of the American people that we've ever seen in many, many years. And I want to thank especially President Bush, who started it, President Obama, who's continued to support this fight. There are others, the late Congressman Henry Hyde and Tom Lantos, who some of you may not even have known or heard about, played such an important role. And now, all former senators, Bill Frist, Richard Lugar, Joe Biden, and John Kerry, really pushed this legislation through Congress. But it's really amazing to sit back and think of all that's happened since 1981 when the virus first came to our consciousness. The things that we thought could never happen, reducing the price of a full complement of AIDS medications from over $10,000 to under $100. More than 10 million people in treatment. I'll talk a little bit more about that, but going from less than 50,000 on treatment in 2001 to where we are today in the developing world is really extraordinary. Now, one of the things that I do in my new job is try to understand the economic impact of all the things that we do. And when PEPFAR was conceived, I don't think that there was a sense that this was going to be a program with very powerful economic impacts. Excuse me for just a second. But I want you all to know that no one should doubt the really extraordinary economic impact that these programs have had. In South Africa, for example, life expectancy rose by 1 year for each year that antiretroviral treatment was made available, from 2004 to 2012. 8 years of recovery in life expectancy. This was called one of the fastest life expectancy recoveries in the history of public health. A recent paper in Science showed that AIDS treatment increased population-level life expectancy in KwaZulu-Natal in South Africa by 11 years, higher than it was before the HIV epidemic. In Kenya, a World Bank study showed that after AIDS treatment, adult working hours increased, child labor decreased, and children's nutrition and school attendance improved. Another study that followed a cohort of 879 patients with HIV enrolled in antiretroviral treatment for 5.5 years showed that the number of patients unable to perform their normal daily activities fell from around 50% to just 5%. Difficulty with job performance fell from 56% down to just 6%. And reliance on a caretaker fell from 81% to almost zero. In terms of increased labor productivity, averted orphan care, and deferred medical treatment, the benefits of antiretroviral treatment are estimated to be 2 to 3 times greater than the cost of treatment. Now, all this in the face of absolute certainty among most experts that this was going to be a financial disaster for the U.S. and even for developing countries. One of the most important studies, and if you haven't read it, you should go out and read it right away. It was led by former Secretary of Treasury, Professor Larry Summers. That study in The Lancet, that was done through the Commission on Investing in Health, found that in low and middle income countries, between 2000 and 2011, 24% of all the economic growth in those countries, in low and middle income countries, in that 11-year period, can be attributed to improved health. So the role specifically of HIV treatment in that is still to be calculated fully, but let me be clear that there's no doubt that the impact was profound. One of the great stories of the last 5 or 6 years is that during the global economic crisis, Africa maintained an over 5% growth rate throughout that entire time. And still, many people who are very familiar with this field are surprised when I tell them that Africa grew at over 5% during that entire time. If no one knew their HIV status, if we had lost 8 million people in that time, if no one was getting tested, and people from the ages of 19 to 54 were dying right enough unpredictably, I have little doubt that the investments that we saw in infrastructure, in human capacity, all the things that we saw that have contributed to the growth in Africa, I can't imagine that those would have proceeded in the same way. You know, the most remarkable study just came off the press. We at the World Bank have been doing randomized evaluations of conditional cash transfer programs. We did it in Tanzania, Malawi, and very recently in Lesotho. And we wanted to see if placing income and choice in the hands of individuals can reduce the transmission of both sexually transmitted diseases and HIV. In Lesotho, adolescents were offered an opportunity to participate in a lottery, not to receive payments, but to participate in a lottery to receive payments of $50 or $100 every 4 months if they stayed free of sexually transmitted infections. The possibility of participating in a lottery reduced the rate of new infections of HIV by 25% in that cohort, and 33% among girls. Now, we're thinking about what are the implications of this study. It's something that powerful. Now we have to try in some other places. But, you know, it's something that Paul Farmer and I were talking about for quite some time, that these things are in some ways are fairly obvious, that lifting people out of poverty, helping them to find a way to avoid transactional sex could have a huge impact. But the other thing we know is that despite the progress, there's still a horrible problem in the world. AIDS continues to ravage the poorest, most marginalized, and excluded communities everywhere. In the US, some 50,000 people become newly infected with HIV each year. We don't have to look far in terms of looking at where the epidemic is. And right here in this city, in Washington, D.C., we have the highest HIV prevalence in the entire nation. What we know, though, is that HIV, like poverty, will require more than just money if we want to tackle it effectively. We have to continue to confront the underlying social and structural factors that drive both poverty and the HIV epidemic. And this will require political will, social activism, and an unwavering commitment to equity and social justice. One of the issues that I want to tackle, that I want to talk about a little bit today, is institutionalized discrimination. It is one of the underlying issues that drives this epidemic. Too many people around the world today face discrimination based on their sex, their age, their race, religion, or sexual orientation. More than 80 countries have passed laws that make homosexuality illegal. More than 100 countries discriminate against women, and an even larger number still have laws that discriminate against minority groups. Institutionalized discrimination is bad for societies, and it's bad for economies, and we can't tolerate it. You know, one of the great ironies is that some of the most draconian anti-gay legislation is being passed in some of the same African countries where millions of people are receiving HIV treatment, thanks largely to the work of gay activists right here in the United States. You know, in my work, and let me just say that at the World Bank, we're trying to be very clear about our own position on discrimination. On the one hand, we know that discrimination against women has a direct impact on GDP growth in countries all over the world. We estimate that in the Middle East and North Africa, the non-participation of women has an over 20% decrease in GDP growth is the result of the non-participation of women. Prime Minister Abe in Japan has said that Japanese growth would be 14% higher if women participated in the workforce at the same level as countries like the United States. You know, at the World Bank, we've set two goals. The first is to end extreme poverty by 2030. And that is, if any of you have read the recent intergovernmental panel on climate change, that is going to be an extremely hard goal to reach. The other goal that we've set is to boost shared prosperity for the bottom 40%. In other words, the bottom 40% of any developing country, we want to do everything we can to ensure that they share in economic growth. These are really hard goals. The United States has set a goal of an AIDS-free generation. Ending AIDS and ending extreme poverty are ambitious goals that I personally believe are achievable in our generation. But on a day like today, I think it's really important for us to be honest with ourselves and look back at what the world looked like in 2000 and 2001 when we began talking about HIV treatment. Back then, as I said, about 50,000 people were on treatment in any developing country outside of Brazil. Brazil had about 150,000 people on treatment. But I think it's really important to go back and remind ourselves of what people were saying. One very highly placed government official said that it's impossible to think about treating HIV in Africa because Africans can't tell time. They know morning, they know midday, they know the dark of night, but they don't have any conception of time. So how can you give people medicines that they have to take on a regular schedule 5 times a day? Already by that time, we decreased the number of doses to about 2 a day. But the point is, that was said in 2001, a very important government official. And he was simply reflecting a very widely held view that it would be impossible and even crazy and even irresponsible to think about HIV treatment. I will never forget the day. I was at the World Health Organization where I was head of the HIV department, and we had launched 3x5. And a person had just joined our staff, and she was a specialist in HIV prevention. And at one point, I forget when it was, but it was an unguarded moment. She looked at me and she said, after I had returned from the Sutu, where we just began the process of talking to them about a treatment program, and she just finally couldn't take it anymore. And she looked at me and she said, "You're just giving these people false hope." Now, a person who lives not too far from here during his campaign once famously said, "There's no such thing as false hope. There's just hope." But what would she have had me do? I was so shocked, I didn't have the wherewithal to ask her the question. But what would she have had me say? You know, there are these medicines that you take once in the morning and once in the evening, and we, by that time, had fixed dose combinations. But you know, it's just inconvenient for us to treat you. So I want to be honest with you, and I want to give you the dignity of knowing that because it's inconvenient for me, you're going to die. That's what the discussion was in 2001. And, you know, lots of people now are reinventing themselves as HIV activists. But we remember what that discussion was like. And I have no interest in going back and saying who said what and who's on what side. I have no interest in doing that. But the important thing is we've got to understand what happened back then. Lots of heroes emerged. And again, let me mention President Bush, because what President Bush and all of the members of Congress that I mentioned, what they did was they actively went against the advice of experts. The experts overwhelmingly were saying, don't treat. You know, we're talking about the next generation. The pendulum has swung too far in the direction of treatment, and that was said when not a single person in Africa had received treatment sponsored by any international agency. And the lesson for me is about the importance of humility for experts. Many of you in this room are experts. Don't ever forget how certain the experts were that treating HIV in Africa is a bad idea. Right? And you know, some of us were saying things like, "Are you kidding me? If we tell 25 million people that they're dead, our generation will be remembered for letting them die." Some of these things are not forgotten. So I want to remind all of us that when you are tackling issues like ending poverty or ending HIV/AIDS, you've got to really look hard at the tension that almost always exists between what people think is morally and ethically the right thing to do and between what the experts say is the right thing to do. And in the middle of that tension, I would remind you of a couple of just basic ideas. First, anyone who works on trying to serve the poor, anyone who works in situations of great poverty, I think should be reminded of something that the great Italian philosopher Antonio Gramsci once said. That he said, in these kinds of matters, when you're thinking about the poor, you have to retain a pessimism of the intellect, but an optimism of the spirit. In other words, I am not asking asking experts to throw out their analysis. I am not asking experts to ignore data. But if you walk into a situation in which 25 million people are infected, in which 25 million people will soon die, and you bring to the table fear, pessimism, even cynicism, the poor are dead. It's deadly. That kind of attitude is deadly. And so in the work that we do, the work that all of us do, we've got to remember that optimism and pessimism is not the result of rational analysis. Optimism is a moral choice. And what an amazing choice that legislators here, President Bush, President Obama, continues. What an amazing choice they made. Because it turns out they were right. They were right not only on the moral issues, but they were right on the economic issues. And so this should be a lesson anytime we let cynicism and pessimism creep into our discourse when we talk about doing the right thing for poor people. You know, Martin Luther King once said, the arc of history is long, but it bends toward justice. But if we learn nothing from his life, we learned that it doesn't bend toward justice unless you grab it and bend it with everything you have for justice. We have a lot of work still to do. I could go on and list all the things that now those who've championed the fight against AIDS, we've now got to take the money that we receive, the moral gift that we receive, and extend it into building healthcare systems, into making sure that the other diseases, chronic diseases, are also treated. But we can do it. It's really, really hard, but we can do it.